Ladies and gentlemen, I want you to focus on this picture. This is a picture of a child having oxygen inhalation at the moment. And one child dies of pneumonia. Every 39 seconds in the world. This is exactly the time, 39 seconds, which you were focusing on this slide. So while we were focusing on this slide, one child died of pneumonia somewhere in the world. And Pakistan is no different. And in this recent year, 2023, which has just passed, a lot of patients, both adult and pediatric population, suffered from pneumonia all across the country, specifically in KP and Punjab. And because of prevailing smog condition in Punjab, particularly in Lahore, and the cold wave, there was a surge in the number of cases, and hundreds of patients had respiratory illness, and many died. So today what I'm going to focus is on the clinical practice guidelines for community-acquired pneumonia in Pakistan. I'm really thankful to the organizing committee of DOCTORSCON for giving me the opportunity to speak to all of you today on this important and burning issue. I would be introducing what is pneumonia to you, give you a classification, tell you about the prognostic factors, how to manage these cases, and then there are some panel recommendations which are by the Medical Microbiology and Infectious Disease Society of Pakistan, endorsed by Pakistan Society of Internal Medicine, that I will be sharing with you today. So pneumonia, as you all know, it is an infection of the pulmonary parenchyma, which is characterized by the presence of acute inflammation, and you have fever, cough, dyspnea, or chest pain. And this is among the leading cause of morbidity and mortality among infections. You can classify pneumonias according to different classification. It could be because of etiology which is underlying, morphological characteristics, and setting. In the etiology, it can be viral, it could be bacterial. In the morphology, it could be lobar pneumonia, or it can have an atypical bronchopneumonia presentation. In the setting, it could be community-acquired pneumonia, which we are going to discuss today. It could be hospital-acquired or nosocomial infection. It could be ventilator-associated pneumonia in immunocompromised patients like HIV and AIDS, and neutropenic patients. These are some of the settings in which you can have pneumonia. But today we are focusing on community-acquired pneumonia, which is a pneumonia that is acquired outside the hospital or a healthcare setting in the community. So whenever you come across a patient with typical signs and symptoms of pneumonia, which is like fever, cough, sputum, chest pain, breathing difficulty, runny nose, dry cough, then you should also ask for duration of the illness. If the duration of the illness is short, that is less than 5 days, it is usually viral in etiology. You should also inquire about the close contacts and similar illness in the household, if anybody else is suffering in the house. Also ask for comorbidities, because this is one of the prognostic factors for pneumonia, like patient having diabetes, end-stage renal disease, malignancy, patients on immunosuppressive drugs, or pulmonary problems like bronchiectasis and COPD. They have bad prognosis when they suffer from community-acquired pneumonia. Always check. Pulse oximetry is one check in which you can check the oxygen saturation of these patients, and if required, you may order a chest X-ray for these patients. Sometimes the patients, they develop the severe form of disease, which is known as systemic inflammatory response syndrome. In this case, the patient has very high fever, which is more than 38 degrees centigrade, or sometimes hypothermia as well. They have tachycardia, they have tachypnea, and the leukocytosis or leukopenia. These are some of the features which suggest that patient is going into a systemic inflammatory response syndrome. Now, always keep in mind that many a times bacteria are not the cause of pneumonia. And there are common viruses which cause pneumonia, like respiratory syncytial virus, influenza, parainfluenza, and now COVID has been added to this list. But in the bacterial causes, Staph pneumoniae, Haemophilus influenzae, and Staph aureus are commonly seen in children. And in these, apart from children, in adults, mostly you come across viral causes like influenza and rhinoviruses. And in patients older than 30 years of age, COVID-19 has been added to the list. So if we classify on the basis of etiology and age, then in the pediatric population, there could be viruses like influenza, parainfluenza, respiratory syncytial virus, or corona. But in bacterial pathogens, Strep pneumoniae, H. influenzae, and Staph aureus are most commonly found. In adults, we have again viruses and bacteria, but in bacterial population, we have Streptococcus pneumoniae, H. influenzae, Klebsiella, and Pseudomonas, in addition to the usual Strep pneumoniae infection. In atypical cases, we come across Mycoplasma, Chlamydia, and Legionella. In patients who are immunocompromised, they are at high risk of gram-negative infections like Pseudomonas and Klebsiella pneumoniae, so you should always keep in mind these causative organisms as well. So just to summarize, children, they have viral etiologies which are common, and the blood cultures and respiratory cultures can help rule out the bacterial causes and co-infections. While in young adults, presentation and severity scores should help guide with diagnostic assay, and they should be sent. In these patients, you should look for Pseudomonas, Klebsiella, and Staphylococcus aureus, in addition to the typical pathogens like Streptococcus pneumoniae and H. influenzae. Now, there are some tests which help you differentiate bacterial causes of pneumonia from the viral causes of pneumonia. And one such test that we come across is the procalcitonin level. There's C-reactive protein and total leukocyte count, which also helps us in determining that probably the cause is bacterial and not viral. And there is proadrenomodulin, interleukin-6, neutrophil leukocyte ratio, and monocyte lymphocyte ratio, which also help us in differentiating bacterial pneumonia, viral pneumonia, and tuberculous and malignant pneumonias as well. Other investigations which you can order are gram stains, sputum culture, blood culture. Serology can be done in some cases. In cases of Legionella, you can order a urinary antigen. But if your patient is having severe pneumonia and you are unable to find the cause, multiplex PCR can help you, the respiratory panel of infections, and this is one expensive but very useful test. In some cases, you require a bronchoalveolar lavage and CT scan chest to know the exact etiology of the cases. Coming on to the severity and prognosis of community-acquired pneumonia, classically we've been reading about CURB-65 score. But there's another score which we use now, which is PORT score. CURB score stands for confusion, urea, U for urea, R for respiratory rate, blood pressure, and A for age. So these are, if age is more than 65 years and it is confusion, urea, respiratory, or BP, this shows a poor prognosis in patients. But now there is another criteria which is based on PORT scoring system. This is Pneumonia Outcome Research Team which has developed this scoring system, and it depends upon the demographic factors, comorbid illnesses, physical examination findings, and lab and radiological findings. In the demographic factors, we have age, whether men or women, number of years, and in women, we number of years minus 10 we take. And then nursing home residents, we take 10 points. In the comorbid illness, we look for neoplastic disease, liver disease, CCF, CVA, and renal disease. In the physical examination, we look for altered mental status, respiratory rate, systolic blood pressure, temperature, and pulse. And in the lab and radiological findings, we look for pH, blood urea nitrogen, sodium, glucose, hematocrit, ABGs, and pleural effusion. So there are a certain number of points which are assigned to all of these, and this helps us in making the prognosis of these patients. So according to the risk classes, according to the points that they are assigned, and then when we'll calculate if the points are less than 70, or then they can be managed in OPD. Between 71 to 90, it is physician's discretion to treat on OPD basis, or inpatient management should be done. But if score is more than 90, these are the severe cases and they should be managed in a hospital setting. These are some of the panel recommendations which I am sharing, which are made by the Medical Microbiology and Infectious Disease Society of Pakistan. This has been endorsed by Pakistan Society of Internal Medicine, and these are based on the data and the literature search recent and the recommendations of the international organizations. So they say that patients less than 65 years of age who have acute onset of illness less than 5 days, like runny nose, sore throat, cough, fever, and no significant comorbidity, they should be considered to have a viral upper respiratory infection or viral bronchitis, and they should be offered supportive treatment like acetaminophen or NSAIDs, antihistamines, decongestants, nasal inhalers, or if required, inhaled corticosteroids and beta agonist inhalers. These patients should be counseled about the clinical course, that it's going to, get better in few days, but if there is worsening of symptoms, then you can go for testing and you can start empirical antibiotics as well. Patients who are older than 65 years of age or younger than 65 but with significant comorbidity, and they have these symptoms of cough and fever, they should be tested, and CBC, CRP, and chest X-ray should be done in these patients for further guidance. If there is elevated WBC count, CRP, or there are infiltrates on the chest imaging, then empirical antibiotic therapy should be started. If patients have normal WBC, mild CRP elevation, and there are no lung infiltrates on chest imaging, then you should not be starting antibiotics, and because this could be viral pneumonia, tuberculosis, or malignancy. But if the patients, they have V's on chest auscultation or has a normal lung examination with saturation more than 25%, this is less likely to be bacterial infection, and antibiotics can be withheld for a time being. In patients, sputum grain stain and culture should routinely be advised, and with CAP managed in the outpatient setting. And patients with viral bronchitis, asthma, pharyngitis with post-nasal drop, they can also have sputum production. So in these patients, tests for sputum, and with infiltrates on chest X-ray, or if they have recent antibiotic use, uncontrolled diabetes, immunosuppression or malignancy, any structural lung disease such as COPD or bronchitis, you should always test sputum of these patients. Patients having severe bacterial pneumonia with saturation of less than 88%, at room air, they should be asked to give a sputum sample, again for gram stain and culture. And if patients have uncontrolled comorbidity like diabetes, and if they present with pneumonia, then there are chances of empyema, and it is recommended to perform a chest X-ray and a CBC in these patients. In patients with COPD or bronchiectasis, this has to be individualized. They are frequently colonizers, and you should think whether you need antibiotics in these patients or not on an individual basis. In patients who are having pneumonia with hypoxemia, empiric antibiotics with testing should be the line of action. In patients with presumed pneumonia and saturation less than 88%, they should be given antibiotics with consideration of inpatient management in these cases. And patients often complain of persistent cough. And most commonly, the most common cause of persistent cough is after viral infections. So post-viral bronchitis, it is treated by giving inhaled corticosteroids and beta agonists to these patients in the form of inhalers. And there is a misconception that you should start antibiotics in these patients. Antibiotics do not help in these patients, and they should be avoided in these patients. If your patient has already taken a course of empirical antibiotics and their symptoms have not improved, then you consider other etiologies and work up for tuberculosis, post-viral bronchitis, malignancy, and interstitial lung disease should be in your mind. And in patients who have a typical illness of fever, cough, but with normal WBC count or elevated or normal near normal CRP, and a chest X-ray with infiltrates, you can treat as viral pneumonia without antibiotics. Even if the patient has hypoxemia, you should not be starting antibiotics. You should get a sputum culture and consider a multiplex pneumonia level by viral PCR, and then based on these, your line of action should be determined. And in these patients, in the recent settings, you should also investigate for influenza or COVID-19 via PCR. The empirical antibiotic treatment of pneumonia should be guided by the antibiotic susceptibility profile of the circulating strains of the bacterial agents of the community-acquired pneumonia. So this is just a brief algorithm. I'm not going into the details, but if your patient has a short duration of illness of less than 3 days, you suspect a viral pneumonia, you give symptomatic treatment, follow them up, and see for the improvement. If it is more than 3 days, but your patient is not improving with the symptomatic treatment or is worsening, then you see for danger signs. And the danger signs are age more than 65, oxygen saturation less than 92%, respiratory rate of more than 20, persistent fever, high grade, pulse of more than 100 beats per minute, systolic blood pressure less than 90, any comorbidities like CKD, CLD, diabetes. And then if danger signs, any 4 are present, then you refer them to a hospital. And if there is worsening of symptoms for 48 hours despite antibiotics and supportive care, then you should start antibiotics in these patients. The empirical antibiotics that we use without comorbidities or risk factors are amoxicillin 1 gram 8 hourly or amoxicillin clavulanic acid combination 625 milligrams 8 hourly. In patients with comorbidities, we can start with monotherapy with respiratory quinolones in the form of levofloxacin, moxifloxacin, etc., or beta-lactamase, which are another option. In severe pneumonia, you can give amoxicillin clavulanic acid combination, ceftriaxone or cefotaxime. If there is a risk factor for MRSA, you obtain the sputum samples for testing, and according to them you give antibiotics, but empirically you can start injection vancomycin or rilazolid. If there is risk of pseudomonas or gram-negative and the patient is having severe symptoms, then the empirical antibiotics should be piperacillin and tazobactam or imipenem or cefepime or meropenem. If there is a risk of aspiration pneumonia and you are suspecting aspiration, then amoxicillin clavulanic acid combination is the drug of choice. Another important and the last message that I want to give you is about pneumococcal vaccine. Pneumococcal vaccine is part of our routine immunization program, and it is administered at 2, 4, 6, and 12 to 15 months as a part of EPI, which is Prevnar 13, but it is not given to the adult population. In many established good healthcare systems of the world, older adults more than 65 years should get a pneumococcal vaccine because it prevents the severity and severe cases of community-acquired pneumonia. So there are recommendations world over by all the physicians, respiratory, infectious disease physicians of giving these older adults, 19 years age, who have specially underlying comorbidities of giving them a pneumococcal vaccine. So this pneumococcal vaccine is not part of the routine immunization, but Prevnar 13 is available in Pakistan, and you can give this vaccination to your older adults more than 65 years of age, particularly those who are having comorbidities, and this should be part of their regime, especially if they are having any respiratory problems. So my take-home message for today would be for you that knowing is not enough. We all know that antimicrobial resistance is escalating, and with the indiscriminate use of antibiotics, resistant organisms are growing up. So we should be very vigilant while prescribing antibiotics to our patients. We should be guided by culture and sensitivity and seeing if we are undue giving antibiotics in viral etiological pneumonias. There is no role of giving antibiotics in viral pneumonias. We should be cautiously determining which antibiotics in which doses and for what duration of treatment needs to be put in to avoid antimicrobial resistance, which is the silent pandemic going on in the world. So knowing this is not enough, we must apply, and willing is not enough, we must do it. Thank you very much for your attention. These are some of the